So for the September MEC Minute, I'm going to take this as an opportunity to review DNR and the DNR status in Ohio. I'm doing this in particular because there's a new state form out that's used to identify patients who are DNR. And it is in effect 1st of September, and for any DNRs that are assigned or signed by a patient after September 1st, this new form has to be used. So I thought I'd use this as an opportunity to review DNR as a whole new process. So what's new is the new form is out. The form is in effect the 1st of September, and anyone who wishes to be a DNR has to sign the form, the new form. Any old forms that are still in effect or they're still out there that have been signed by the physician and by the patient, they are still in effect as long as the patient wants to be in a DNR. But if after the 1st of September the patient wants to be DNR, they have to use the new form. Also this year, something new is that nurse practitioners and PAs can sign the form. This was approved by the Ohio Department of Health several months ago. It does allow others to sign the form as independent practitioners, but there are some issues at play regarding Ohio Revised Code that covers EMS providers and the Ohio Department of Health's administrative rule, and I'll discuss that conflict a little bit later. There's also now, and there has been in place, the ability for us as EMS providers to take verbal orders from patients' physicians, and there's an expectation that if you take a verbal order, you have to verify the order, and we'll talk about that later as well. The Ohio Department, the Ohio Department of Health, not the Board of Health. The Ohio Department of Health is releasing updates on this new form via PowerPoints. They're going to be made available to EMS as well as the public and the healthcare providers. Currently, there is one out there for the public, and there's one for healthcare providers that's been provided by the ENA, the Emergency Nurses Association, but the specific PowerPoint for EMS is yet to be released. So going back to the beginning, what is a DNR? Do not resuscitate order, or DNR, allows patients or individuals to identify their choices related to CPR should they suffer a life-ending event or be approaching a life-ending event, specifically or particularly if they're terminal. As an individual, patients have the right to document what they do or don't want to be done in regards to CPR or other resuscitative measures. So who can complete the form for an individual? Well, currently a DNR may be completed by a physician, advanced practice nurse, an APRN, or a physician assistant with their patient's consent. The providers are referred to as authorized healthcare providers, and they're kind of that way through the rest of this PowerPoint. Really, there are two types of DNRs. There's the DNR Comfort Care, which we're used to seeing, as well as the DNR CC Arrest. The difference really between the two is when the DNR protocol becomes effective. And the DNR protocol, as outlined by the state, lists the actions that a healthcare provider will and will not take while they provide care for the patient. So a DNR CC is in effect as soon as an authorized healthcare provider signs the form. So as soon as a physician, nurse practitioner, or PA signs the form and dates it, then it is in effect, and the treatments that are listed in the DNR protocol is will not or will or may go into effect. So it identifies those things that you can't do, which includes resuscitative medication, CPR, ventilation, cardiac monitoring, or defibrillation. DNR CC Arrest essentially means that it does not become in effect. The patient's wishes regarding resuscitation do not go into effect until they suffer a cardiac or respiratory arrest. So a patient can be quickly deteriorating. You may determine that they need to have an artificial airway, and if they have not gone into a cardiac arrest or a respiratory arrest, you could still provide that intervention. So if a patient's very short of breath and you think they would benefit from an airway, you can put that airway in as long as they have not progressed to the point of being in a cardiac arrest or a respiratory arrest. And all care can be provided up to that point, including pressors and everything else. So that's kind of what's in effect. And then once patient goes into cardiac arrest, then you do not provide any additional resuscitative efforts. So if you get on scene, the patient is short of breath, you intubate the patient, because they appear short of breath, and then they suffer cardiac arrest, you terminate your resuscitative efforts. I think if you get there and the patient needs an artificial airway, you're not going to see an episode of respiratory arrest because you're going to be bagging them or ventilating them after you place the tube. So from my perspective, once the patient's intubated, the only time they're going to suffer arrest is if they suffer a cardiac arrest. So let's talk for a moment about this new form. So the new form's a one-pager, and it pretty much has taken what's been on the two-page form and put it on one. So on this form, the patient has the option to sign the form, but the form is not really in effect until the physician signs the form, or a independent licensed professional. So a physician, an MD or a DO, a physician assistant, or a PA. So someone who's licensed by the state of Ohio to practice independently has to sign the form. The form is in effect once that provider signs it. The patient may sign the form if they desire, but their signature is not needed in order for the form to be in effect. It's the healthcare provider's signature that puts that DNR form in effect. If a nurse practitioner or PA signs it, they also have to identify the collaborating physician or the supervising physician who is overseeing their care. So if one of my nurse practitioners signs the form, then they have to identify me as being the collaborative physician, otherwise the form's not fully in effect. The other thing to keep in mind is with this form, the state has specifically stated the form cannot be modified. So in the past we have seen forms that say patient is chest compressions only, do not intubate or intubate but no chest compressions. So those things are not allowed. Either the patient is a full resuscitation, they're DNR-CCA, or they're a DNR-CC. If anything else is entered in this form, it has no effect on what you do. You can only follow the wishes of the patient in terms of DNR-CC, DNR-CCA, or if there is no form or no signature, they're full resuscitation. And that's what is identified here. So either they're a DNR-CCA or they're DNR-CC. The other thing about this form is, while it was implied before, it's now specifically outlined that we can use CPAP and BiPAP, and we can also use fluids for rehydration. IV fluids can be given as long as they are not be given as an attempt to resuscitate the patient. So if the patient looks a little dry, they feel thirsty, and they would like some IV hydration, you can start an IV. If their pressure is 60/40 and they need IV fluids to bring their pressure up, that would be considered resuscitative fluids, and we would not give them IV fluids in that circumstance. So the DNR protocol, this is very similar to what you're used to seeing. If the patient, or once this is in effect, we will provide initial assessment. We will provide basic medical care. We can clear the airway of obstruction, or we can suction the airway if necessary. We can administer oxygen, CPAP, or BiPAP if we're doing so for comfort measures. So if we're doing it for resuscitative efforts, the answer would be we don't do that. But if we think the patient would benefit from a comfort perspective by receiving oxygen, CPAP, or BiPAP, we could start that. Again, we can start IV fluids and obtain IV access for hydration or administration of pain medication, but not prolong death. So we cannot give them fluids if our intent is to keep them alive longer. And then if possible, and if necessary, we can contact other healthcare providers such as hospice, home health, physicians, PAs, nurse practitioners, if we need to, for guidance regarding the patient's care. Again, specifically, it now says that we can use CPAP, BiPAP, and IV hydration. The CPAP and BiPAP was implied with the previous form, but not specifically called out. In terms of what we will not do anything that can be considered CPR. We will not use any airway adjuncts, whether it's an intubation or a ventilator. Again, keep in mind, this is an effect for a DNR-CCA patient only upon cardiopulmonary arrest. So you can insert an airway in a DNR-CCA if they are uncomfortable or show dyspnea but have not yet gone into cardiopulmonary arrest. We cannot use any resuscitative medications or any medications with the intent of restarting the heart or breathing. We will not pace the patient, cardiovert the patient, or defibrillate the patient, and we will not start continuous cardiac monitoring. So, if you want to put the blood pressure cuff on to measure the patient's vital signs, and you do that by way of your monitor, that would be okay. If you need to put the cardiac monitor on to determine the patient is dead, that is okay. But we would not routinely start the patient on cardiac monitoring as part of our transport process if they are a DNR-CC patient. So as a matter of definition, what does prolongation or prolonging death mean? Well, for the purpose of DNR, prolonging death means providing care with the intent of keeping the person alive as opposed to providing care for comfort purposes. So when you do something for the patient, you have to think, what is your purpose for doing this? Are you doing this action or performing this action to help the patient be comfortable, or are you performing this action in order to prolong death or attempt to resuscitate the patient? And that should really be how you think about what you do or do not do for a patient who's a DNR-CC or a CCA. How do we identify the patient? Well, I think this is all that you understand. You have to see a form that's got the Ohio DNR Comfort Care logo on it. And that can either be the form itself or a wallet card, a wristband, or a bracelet. You could also identify a patient by receiving a verbal order from the patient's physician, nurse practitioner, nurse specialist, or PA. Any printed items that you're going to follow have to have the state logo on it. And here's another version of that logo. So what happens if the patient wants to stop or change their code status? They say they're DNR-CC and now they want to become a full resuscitation. Well, it's really simple. All they have to do is take off the armband or take off the necklace or tear up the form and let people know that they want to be fully resuscitated. So a patient at any time can change their mind, and it's very simple for them to do so. Sometimes the question comes up is, who can change a patient's DNR? Well, the patient has the right to change their DNR at any time. And it can again be by simply destroying whatever method is being used to identify them as a DNR patient. A patient's healthcare power of attorney cannot change or override a patient's DNR status if the patient completed the DNR form with their healthcare provider. So no one can overrule a patient. If the patient at some point in their life says, I am now a DNR-CC, they sign or have their physician sign the form. That form is in place until the patient revokes it. So no family member or POA can revoke that form. Now, if the POA requests that the patient be made a DNR, then the POA, healthcare power of attorney, can request that the DNR be revoked. So that is something that's in place, but the DNR can only be revoked by a healthcare power of attorney if they are the one that asked for it to be started to begin with. Again, if the patient requests to be a DNR, no one can revoke that except the patient. Another physician or medical director of EMS cannot override a patient's DNR decisions if the patient completes the form with their authorized healthcare provider. So if the patient is a DNR, we can't change that unless the patient specifically tells us that they are revoking their DNR status. And then family members cannot override the patient's DNR decision, and if particularly it's been signed off by the patient's physician. So again, we get back to can the DNR be customized to include a list of what the patient wants? And the bottom line is no. The form is what it is. So no other medical orders, directions, or instructions can be written on the DNR. And if they are, they have no effect on what you do. Anything written on a DNR form other than what's required for the form as it's currently printed has no authority over you in terms of what you should do, has no authority over the DNR statute or rules. It does not hold the force of law in terms of DNR actions, and is not part of the immunities authorized under the DNR law and rules. And I think you need to understand that. So you are protected by state statute from any liability if you honor a DNR order and if you follow a DNR order. If the DNR order is modified with additions to it and you follow what that says, so let's say the DNR form says intubate only but no CPR, or CPR but no intubation, and you do that and something comes out of this process, something in terms of a lawsuit or any other concerns about care, you are not protected by the Ohio statute if you follow anything other than what's currently printed on the form. So let's talk a little bit about that conflict that I talked about with nurse practitioners and PAs versus EMS laws, as well as patients who may be in a healthcare facility who are identified as a DNR. So starting with the healthcare facilities, if the patient, let's say, is in a nursing home, the nursing home physician or the patient's physician at the nursing home can write an order in the patient's medical record that the patient should not be resuscitated, or that the patient's DNR-CC or CCA, or patient is chest compressions only without intubation. Those things all have an effect on the patient and the staff at the nursing home. That written order has no effect on you, meaning you are not in a position to follow that order. Now, if the patient has an Ohio DNR form there at the ECF and it's available for you, or they have an Ohio DNR bracelet on, you do what that says. But if it's just a written order in the medical record without the appropriate DNR logos and forms, you are not held to that order. So you have to keep that in mind, particularly if you're going to be transporting the patient. Well, how do you get around that? Well, you can ask to see the DNR form. So, if the staff says the patient's a DNR and you're going to transport the patient to the hospital, ask to see the form, particularly if you anticipate you may have to resuscitate the patient during transport. Another option is to take a verbal order from the patient's physician, but then you have to verify that order, which I'll talk about in the next slide. So you can take a verbal order from the ECF or the nursing home physician, but the staff has to call them, and then you have to verify the physician's identity. Another potential conflict for EMS is this conflict between the Ohio Department of Health changing administrative rules that say that now a nurse practitioner or a PA can write a DN order, and that's in direct conflict with the Ohio Revised Code, which says that EMS providers can only follow orders or follow protocols as authorized by a physician. So nurse practitioners and PAs are not permitted by Ohio law to direct your activities as a medic or a EMS provider. So there's a potential conflict there. And Carol Cunningham, the state EMS medical director, has specifically identified this conflict. The Ohio Division of EMS advised the Ohio Department of Health about this conflict, but ODH proceeded with this new form anyway. So what are you going to do? Let's suppose you were called on scene. The patient has an Ohio DNR-CC form. It is signed by a nurse practitioner or a PA, and it says the patient's a DNR-CC. What do you do? Well, I think if the patient is going to be a simple transport, you do not anticipate having to provide any life-saving measures, take a copy of the form with you and transport the patient to the hospital. If, however, you think the patient is dying and is going to require life-saving interventions, you have to somehow verify by a physician, get a physician order to honor the form. Another option is to see if there's some other form of identification of the patient being a DNR, such as a bracelet or a wallet card or a necklace. And if it shows that they're a DNR, then don't even ask for the form. Just go with what the bracelet has, because the bracelet doesn't have a signature on it. But I think if you are concerned the patient's going to die en route and a nurse practitioner or PA has signed the form, then call medical control and ask for approval not to, or to honor the form. You can call me, or you can call the medical control via the hospital physicians on duty in the emergency department. So it's a tricky subject. I don't know how big a deal it's going to be. I don't know how common it will be for nurse practitioners and PAs to sign forms. For me, the simplest way to get around it is if they have a bracelet, go with the bracelet, don't ask for the form. How do we verify an order? So you can receive a verbal order from a physician to not resuscitate a patient. And if you receive that order, their name should be identified in the run sheet, but the state expects you to verify their identity. Either you have personal knowledge of the physician, so you know it's a physician in your community, or you have a list identifying physicians in the community, like going to the state medical board's webpage, or you can call the provider back to verify their identity. I think that's probably the easiest route. So if they call you on a phone, just call them right back and verify they are who they are. What do you have to document? Well, the state says that if you're going to follow the DNR protocol, you have to document the item that identified the patient as a DNR. You have to how you verified the identity of the patient, and you don't have to go searching their pockets. But if family member says this is John Smith, and the DNR form says John Smith, and the form is appropriately signed, you've verified the patient's identity. You have to document whether the patient's a DNR CC or CC arrest, and you have to document any actions you take to implement the DNR protocol. And those are all straightforward. You should make that as part of your routine. One final statement or comment about interfacility transfers. If a facility is discharging a patient with Ohio DNR order, and that patient is being transferred to another facility, then the sending facility must provide a copy and notify the receiving facility of the DNR status. Or they must provide some other authorized form of the DNR identification, whether it's a wallet card, necklace, or arm bracelet for the patient. And then the transporting provider, that would be EMS, must be notified of the existence of the patient's DNR. So I'd like to conclude this conversation with a couple scenarios, because I know I always receive what ifs, and sometimes the scenarios help answer the questions. So under the first scenario, you have a patient who has a DNR form signed by their doctor, and it says that the patient's a DNR CC arrest. You evaluate the patient, and you find the patient struggling to breathe, and you think the patient needs to be intubated. Is this allowed? So the answer is yes. So the patient's a DNR CC arrest. They have not suffered yet a cardiac or a respiratory arrest. So if the patient needs an airway intervention, you are able to provide that, because again, they have not had a cardiac arrest or a respiratory arrest. So for this patient, the DNR protocol is not in effect yet, since they are a DNR CC arrest. Second scenario, patients completed a DNR form with their doctor and have chosen to be a DNR comfort care. Patient's now on hospice and has declined to the point that their breathing is very shallow. The patient is hypotensive and death is imminent. Family members are upset and frightened. They call 911, and when you arrive, they want all heroic measures taken to revive the patient. What should you do? Well, this is a point where you calmly talk with the family members and explain to them that the patient has a valid DNR CC and the patient will only receive comfort care, and by law you have to provide only comfort measures, and that there will be no resuscitative efforts. Scenario 3, patients completed a DNR form and have chosen to be DNR comfort care. They're found unresponsive with an empty bottle of Percocet at their side. You are called and you find the patient to be cyanotic and breathing 4 times a minute. You suspect the patient suffered a narcotic overdose. Should you treat the patient with Narcan and ventilate the patient with a BVM? And this is a common scenario that has been posed to me by providers over the past year or two. And the answer is no, you should not treat them with Narcan or ventilate. In this case, Narcan and ventilation with a BVM would be provided with the intent to prolong life. The DNR statute does not discriminate between natural cause of death and any accidental or intentional acts that may result in a cardiac or respiratory arrest. So it doesn't matter why the patient is having trouble breathing or is in arrest or is an impending arrest. If they are covered by the DNR CC or CCA, then you simply do not resuscitate. It doesn't matter what caused them to get there. So it could have been an accident. It could be something intentional. It could be a suicide attempt. It doesn't matter what's gotten them to this point. If they are a DNR CC or a DNR CCA that is in effect, then we do not resuscitate the patient. Finally, you're dispatched on an MVC and you find a patient with an obvious femur fracture and bleeding from multiple wounds. The patient's in considerable pain, and on secondary survey you find an Ohio DNR CC armband. What do you do? Well, I think you should provide routine trauma care. DNR does not mean no care. So you can provide routine assessment. You can provide non-resuscitative IV fluids, particularly if you need IV access for pain control. You can provide reasonable hemorrhage control, but I don't think you could justify TXA because the purpose of TXA is to prolong life. And you can splint fractures. Because the patient's a DNRCC, treatment options do not include intubation or cricothyrotomy, CPR, or even release of tension pneumothorax, because tension pneumothorax would be seen as an attempt to prolong life. So I think this is a pretty good example of the limits of what you can and can't do for someone who may or may not be dying in front of you. So that's my last slide. Hopefully this has been a good review for you. If you have any questions, feel free to post them on Workplace or send me an email. Thank you.